defect requires assignment of a code based upon the location and the approximate description, okay, of the area required. So no need to worry, we will check in the code description after looking for this image. So basically this is one type of advancement flap. Okay, so this is the original wound. Another terms you will call it as primary defect. So this is the area 1. Okay, so this is the secondary defect from where physician will move tissue to this primary defect. Okay, so basically primary defect is the primary wound excision area, and secondary defect is the because of this movement of skin from second adjacent tissue to the wound area or primary defect. Okay, so here it is, our primary defect is 1 centimeter. Okay, so for this 1 centimeter wound, physician has moved the skin from adjacent area. So after moving the skin, so patient will have secondary defect. So this is the area 2. Okay, so they have provided here guideline. Area 1 is equal to 1 into 1. So basically original defect area. So this one is 1 centimeter, this is 1 centimeter. So this is the 1 square. Here they have mentioned in the centimeters, correct? So in order to code adjacent tissue transfer codes, if you check the code descriptions, all include square centimeters. Okay, so here we need to convert centimeters to square centimeters. For example, in the documentation, physician will tell like 3 centimeter into 5 centimeters. So that time we need to code it as 15 square centimeters. But just basically we need to multiply. Okay, so like that, here length is 1 centimeter, width 1 centimeter. So they have multiplied and they have converted centimeter to square centimeter. Okay, so next one is the area 2. Okay, so here 1 centimeter into 2 centimeter. So height of the secondary defect is 1 centimeter only. Okay, and width is 2 centimeter. Here also same, they have combined. Okay, so 1 into 2, 2 square centimeter. Okay, they are here also they have multiplied height into width and they have converted into square centimeter. Okay, next, in order to code properly ATTs, they have combined area 1 plus area 2. So here area 1 is the dimension of the primary defect, which is the original wound. Okay, so area 2 is the tissue transferred area from where physician has transferred the tissue. Okay, so this is area 2 is equal 2 centimeter based on this calculation. Okay, so here we need to combine 1 square centimeter plus 2 square centimeter. So totals it 3 square centimeter. Okay, so here the important concept is whenever you want to code SN to tissue transfer, we need to combine primary defect as well as the secondary defect which will occur due to transfer of the tissue to the wound or primary defect. Okay, so that is the guideline. So here just basically physician will inside the skin on the adjacent area and he will move this tissue on the wound area. Okay, so we are having another type of Asian tissue transfer. Okay, so this is the rotational. See, after completing this tissue transfer, this is the original or final image here. So this is the wound and physician created incision in this area and physician pulled the skin onto the defect area. Okay, so and afterwards performing this movement on the defect, physician will close secondary as well as the primary defect using the sutures. Okay, so this is the one type of asset tissue transfer. Here just physician will create the incision and he will pull skin or tissue onto the primary defect. Okay, so next one is rotational flap. So basically in adjacent tissue transfer, we are having one more technique is rotational flap. Okay, so here patient is having the original defect. So here also 1 into 1, 1 square centimeter. Okay, this is the area 1. Okay, so next this is the and area 2 is the rotational flap basically. Okay, here physician will rotate the skin. He will not pull the skin here. He will rotate the skin from the secondary defect area. Okay, so if you see this one, this is the width of the defect or width of the flap. Okay, see this is 2.5 centimeter and the height of the uh, rotational flap is 1.2 centimeter. So if you multiply this one, it will comes under 3 square centimeter. Okay. So here also same. So they have combined area 1 plus area 2, it equals to 4 square centimeter. Okay. So here is the uh, final closure or final rotational flap closure. So this is the primary defect, and physician has created the incision here and he will rotate the skin. Okay. So that is the images or anatomy related to adjacent tissue transfer. Okay. After final moving the or rotating the skin, physician needs to perform the suturing. Here this is the suturing. So this is the guideline. Just always whenever you want to code adjacent tissue transfer, we need to combine primary defect as well as the secondary defect. And whenever you want to code adjacent tissue transfer, you need to check what is the dimension of the uh, size lesion measured in the operative report. If it is in the centimeter, we need to convert it to square centimeter. Why means our codes are having square centimeter guideline. Okay. So now we'll see few guidelines related to adjacent tissue transfer. Okay. So this is the adjacent tissue transfer. Okay. So codes 14,000 to 14,302 are used for excision and repair by adjacent tissue transfer or rearrangement. Okay. So we need to use these codes for adjacent tissue transfer or rearrangement. Okay. So in the operative report, most of the time you will see the most important keywords are Z-plasty, W-plasty, YV-plasty, rotational flap, random Heisland flap, advancement flap. So in the operative report, if you see all these keywords, you need to code adjacent tissue transfer. Okay. So that is the guideline here. So next one is undermining alone of adjacent tissue to achieve closure without additional incision does not constitute adjacent tissue transfer. So that time we need to use complex repair codes 13,100 to 13,160. So what they are telling is, so if you want to code for adjacent tissue transfer, without this incision you can't code adjacent tissue transfer. Okay. In order to code adjacent tissue transfer in the operative report, near the defect, if the primary defect, if the physician performs any type of incision or not. Okay. So most important guideline for ATT is physician needs to perform incision, then physician needs to move or rotate the tissue from the nearby areas. So that is the guideline, important guideline here. Okay. So if in the documentation you see undermining, so physician will tell I have performed the undermining and I have performed the closure. So that time you will not code adjacent tissue transfer. If the physician performs only undermining, you need to code from complex repair codes. Okay, you can't code adjacent tissue transfers. So next most important guideline is excision of benign or malignant lesions. We will not code along with adjacent tissue transfer codes. Okay. So for example, patient has excised malignant lesion on the neck, and along with malignant lesion, patient has performed the adjacent tissue transfer. Okay. So here we will code only adjacent tissue transfer code. So here we will not code malignant lesion excision code. So that is the guideline. So see here, the excision of a benign lesion or malignant lesion is not separately reportable with these ATT codes. Okay, so directly they are telling if the patient performs benign or malignant lesion along with adjacent tissue transfer, you can't code this one, or you can't code excision code separately along with the adjacent tissue transfer. Okay, so here is the skin graft necessary to close. Secondary defect is considered as additional procedure. So, okay, so for example, physician has pulled skin tissue from nearby area to the wound. Okay, so that time after performing the procedure, if the patient wants to, or if the patient's condition necessitated the perform the skin graft on the secondary defect or donor area, you need to clone that secondary defect separately. Okay, so that is the guideline here. So this is for secondary defect. If the patient performs this skin grafting, you need to code separately. Okay, so this is the most important. Already we have learned here. So for purposes of code selection, the term defect includes the primary and secondary defect. Okay, so as we have discussed, this is the primary defect, this is the secondary defect. Okay, so the same one they are telling here. Okay, So the primary defect resulting from the excision, correct, and the secondary defect resulting from flap designed to perform the reconstruction are measured together to determine the code. So basically they are telling that in order to code ATTs, you need to combine primary defect as well as the secondary defect combinedly, and you need to add both defects and you need to code. Okay, so I hope so far it is clear for you. So next we will see codes. Okay, so Asian tissue transfer or rearrangement trunk defect 10 centimeter 10 square centimeter or less. Okay, so most of the time we will use and 14001 is for defect 10 to 10.1 square centimeter to 30 square centimeter. Okay, so most of the time in the live coding we will see these codes for breast procedures. Okay, so and breast also, each and every breast procedure we will not code these procedures. So along with breast reconstruction codes we will not use ATT codes. Okay, like that we need to remember. After 19357 CPT code we will not use these adjacent tissue transfer codes along with the breast reconstruction codes. Okay, so see here, if the patient performs adjacent tissue transfer rearrangement on the trunk area, here defect is, here we need to combine. Here defect means primary plus secondary defect. Okay, so we need to combine those two and we need to take it as 10 square centimeter or less. Okay, so here is 10 square centimeters to 30 square centimeter. Okay, for example, patient is having the wound on the trunk area. Okay, so wound is primary defect or wound size is 2 square centimeter. Okay, so in order to perform ATT, physician has performed secondary defect which is having 5 square centimeter. Okay, here original wound area is 2 square centimeter and flap design or secondary defect age is 5 square centimeter. So here we need to combine both second primary as well as the secondary defect, as it totals 7 centimeters. 2 plus 5. Primary defect is 2 square centimeter and secondary defect is 5 square centimeter. It totals 7 square centimeter. Here we need to code 14,000. Why means if you see this code description, so you need to use 14,000 per 10 square centimeters or less. So like that we need to use 14000 and 14001 per trunk area. Okay. So basically, and next we are having 14020 and 14021. Okay, so basically these are based on the area of the ATTs. So 14000 to 14001 are for trunk area. Okay, so you can't code this 14002 14001 for other areas. You need to use only for trunk area. Okay, so if you see 14020 to 14021, these are, we need to use if the patient performs ATT on the scalp wound, arm wound and under legs. Okay, so here also based on the defect size we need to code, and also try to remember, so defect means here this defect equals to primary defect as well as the secondary defect. Okay, so here also based on the defect size we need to code. Okay, so next we are having 14040 to 14041. Okay, so here also based on the location. So first series is, first group of codes are for trunk area. Okay, second group of codes are for scalp, arms or legs. Okay, third groups of codes for forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands and feet. Okay, so based on the anatomic location we need to code these ATTs. Okay, so next we are having eyelid. So this is the fourth category or fourth anatomical location. Okay, what are the primary codes here? 14000, 14020, 14040 and 14060. Okay, only difference is here location or anatomical location of the defect area and ATTs. Okay, so here also our dimensions are same. All are having defect 10 square centimeter or less here, and defect 10.1 square centimeter to 30 square centimeter. Okay, defects are same. Okay, anatomical locations are different. Okay, so like that. So next we are having 14301 and 14302. Okay, so 14302 is add-on code. Okay. So here when do you use 14031? So for example, patient is having first code is 30 square centimeters to 60 square centimeter, 14301. Okay. And 14302 is for additional 30 square centimeter or part thereof. So for example, patient is having the wound on the leg area. Okay. So physician has performed like 90 square centimeter Asian tissue transfer. So how do we code that one? So first we will code 14301 for 60 square centimeter, and remaining 30 we need to code 14302 one time. Why means each additional 30 square centimeter. Okay. If the patient performs ATTN 90 square centimeter, first we need to code 14301 which is for 60 square centimeter, and additional add-on code for remaining 30 square centimeter 14302. So here most important thing you need to remember here, if the patient's defect is more than 30 square centimeter, you need to use 14301 and 14302. Okay. So you can't use 14002, 14061 codes if the patient's defect and defect area is more than 30 square centimeter. So if you see the code description here, they are clearly mentioned Asian tissue transfer or rearrangement any area. So irrespective of the area, we can use 14301 and 14302. The important criteria here is defect size must be more than 30 square centimeter. Okay, so that is the guideline here. So sometimes what happens most commonly, so if you see the a physician will perform pilonidal cyst and he will perform the ATTs. Okay, so that time you can code pilonidal cyst separately and ATT separately. Okay, so that is the CPT guideline. Okay, so I hope this session is you can fully. So if you are having any doubt during the live coding, please try to consult me. Okay, so like that. So here first you need to check location of the defect. Okay, so next you need to check diameter of the defect. Okay, and diameter also you need to check. So if the patient mentioned their diameter in the centimeters, you need to convert into square centimeter. Okay, then how do you code multiple wounds in the same area? Okay, if the patient performs 82 multiple wounds in the same area, we need to check the continuity or whether these lesions are contiguous or non-contiguous, or the if the lesions are non-contiguous, we need to code two adjacent tissue transfer codes separately. Two lesions on the arm area, so both are having different margins and they are not related, so that time we will code both adjacent tissue transfer codes. Okay, so that is the, so thanks for watching.